It's a sunny Southern California day, and I'm finally getting around to editing and publishing the videos, some of them that we recorded at the Southwestern Ultrasound Fellowship Conference, or SURF conference, that Deja Essner and some of really all of the ultrasound directors, fellowship directors in Southern California actually participated in. It was just such a good conference. We learned so much. The conference itself is meant to be a little bit more for ultrasound fellows and early ultrasound faculty. So some of the lectures were just like, I learned so much from them. The first one that I'm going to talk about is one that Dana was able to give us. And Dana talked about just a really good right ventricular ultrasound lecture. Starts out with some basics and talks about a bunch of other stuff, and I really feel like it's so relevant to emergency physicians wanting to take their ultrasound to the next level, which is what we always should do. We should always try to improve ourselves a little bit. A little bonus is that he actually taught me a name that is now the name of my favorite all-time study, because the name is just amazing. It's called the TAPSE study, and I'm going to put a link in the show notes. Please check it out. If not anything, I mean, it's obviously good data, but just for the name, because we need to encourage that. Check out the video.
Thank you, everyone. My name is Dana Sajed. I run the Clinical Ultrasound Fellowship at LA General Medical Center, formerly known as LA County USC. Thank you all for having me. I have the shittiest time slot of the whole day. First of all, everyone got to give a cool lecture except for me. Everyone was like, oh, do some ultrasound in space, and then your lecture that is coming after me is going to suck because of all this shit. And then like everyone was talking about cool stuff, and then I'm going to be like, put the probe and like get the pulse wave Doppler. That's what I got. So thank you very much. And that's what it is. And it's like after lunch, and the day, it's a long day. So great, awesome. So just show of hands, who are fellows in the room? Sorry, I know a handful of people, but I don't know. Okay, great. So I'm going to talk about the right ventricle, and I have no financial disclosures. I'm more than willing to sell out if anyone wants me to shill any products for them. I don't care. I'll put my name on anything. Just pay me and I'll do it. So I want to start with kind of why I bother even, I like talking about this topic, and my two poor fellows have heard this, and like my former fellows have heard this, and I go on and I drone on and on for them about this like right ventricle stuff, because to me it's very interesting. But as an emergency physician, the reason I like this topic is because the clinical relevance is in interesting cases to me, in my mind. 90% of the time it's going to be pulmonary embolism. Sometimes it's going to be, maybe a patient with an MI or a septic patient with myocardial suppression. There's other cases where looking at the right ventricle or looking at the right heart really matters. Most of the time it's going to be PE. But at the end of the day, I'm an ER doctor. There's 50 patients and a bunch of them are sick, and this is going to help me take care of those patients. So that's kind of why I bother like droning on and on with fellows and residents and other people about, oh, look at the right heart and do this and that. So this is kind of our roadmap for the day. We're going to look at a little bit of anatomy of the right heart, and then we'll talk about how we assess the size of the right heart, because that correlates with function. We'll talk about how to quantify right heart function. We'll look at some right heart hemodynamics, and then I want to bring it together with how I kind of think about this clinically, or how it can be used clinically. All right. So we'll start by talking about right ventricular anatomy. And again, this is review. This is something everyone in here knows. We're looking at an apical 4-chamber view of the heart, and we see the moderator band and the chordae tendineae. I like to start with this one because invariably, every year, everywhere I've worked, there's at least one well-meaning resident who gets this view and looks at that and doesn't recognize that the moderator band is a normal finding, and will say, oh, snap, there's a clot and there's a thrombus in the RV, and this patient gets a whole lot more workup than they really need. So I like starting with this image in particular because it just illustrates a nice normal view of things that we should expect to find. Okay, RV anatomy, I know you can't see the chart. The point isn't to see the chart. The point is to know that it's different than the left ventricle, right? So we're talking about not just two different chambers, but two entirely different like organic systems here. The RV is, as you know, very thin-walled. What does that mean? Well, it means it responds to preload and afterload very differently, and it's very sensitive to afterload against it because it's so thin-walled. The architecture and the geometry of myocytes in the RV are different than they are in the LV. And during systole, it contracts differently too. And again, this is something you all know, right? The RV tends to contract in an up and down fashion when we're looking in the apical view. The LV tends to have a squeezing and contracting closure that we can see when we're looking at the left ventricle. All right. As far as the nomenclature for the anatomy and what we're looking at, it's basically divided into four main sections. There's an inferior, lateral, and anterior wall, and then there's the area we call the infundibulum. The infundibulum is what you see when you look in the peristernal long axis view of the heart. That part of the right heart is called the infundibulum. It lies just below the pulmonary vessels coming off. The apical four-chamber view, you're generally going to see the lateral wall, and in the subxiphoid view, you're generally going to see the inferior wall. Keep that in mind, because when we're talking about how we assess the right heart, remember, you're looking at hopefully multiple views of the heart, but most of the time you're going to be looking at one wall at a time. All right. The vascular distribution in the right ventricle looks like this. Most of it are vascularized by branches of the right coronary artery. So the lateral wall that we see in the apical four-chamber view is from an acute marginal branch. The infundibulum is from the conus branch. And then that intraventricular septum and the moderator band are usually vascularized by the LAD. Okay, so that's what the RV anatomy looks like. I'm putting up a picture of the LV again, and I'm talking about LV function. We talked about how the anatomy of these two things are different, right? It's just a different chamber. It's oriented differently and the shape is different. What does that mean? Well, when we're assessing the LV, it actually makes it pretty easy, and everyone in here knows how to do this, right? And like, we just look at the LV and you see how much the walls collapse, you see how much the mitral valve opens and closes, and pretty much anyone can do this. Medical students, internists, intensivists, emergency physicians, it's been studied in every group, and we're all very good at assessing LV function with an eyeball estimate. The problem is the RV doesn't beat the same, it doesn't contract the same. So it's a little bit more challenging to assess the RV. And so when we want to functionally assess the RV, we can do a couple of different things. Oh, all right. The first is to look at RV size. So remember, I mentioned that it's thin-walled, and it's very sensitive to preload, volume, and afterload. So specifically, any change in the RV afterload is going to cause dilation of that RV, right? It doesn't respond to pressure very well, so it's going to dilate. So the first thing you're going to see is actually enlargement of the right ventricle with change in afterload. So again, as a corollary of function, we can use RV size. So again, we're going to talk about RV size because RV size is something that kind of makes a difference in how we assess the RV and what we think what is going on in the RV. All right. There is a technical way to measure this. You can go from apex to base, you can measure it with at the mid and basal segments, and you can calculate volumes, and you can look at charts in normal size. I'm an ER doctor. Last night I worked a shift, there were 75 patients in my waiting room. Ain't nobody got time to do this. My boss will fire me if I sat there and did this on patients. So what we do is actually just look, and thankfully looking is generally good enough. We know that the RV should be roughly 2/3 the size of the LV. Lots of literature showing that. And we know that if it looks bigger than that, specifically if it's roughly even 1-to-1 ratio from right to left heart, then that means something abnormal is going on. That right heart is abnormal if it's roughly equivalent to the same size as the left heart. And again, thankfully, a bunch of people have studied this, and they found that if you just eyeball and you estimate this, you're pretty much just as good as anyone who is measuring all of those segments of the RV as well. So your eyeball estimate is just as good. Another sign of RV enlargement you can look for is looking at the apex of the heart. Remember, LV is the big chamber. Normally the apex should be LV dominant. In the setting of RV enlargement, sometimes what you'll see is encroachment of the RV apex and taking over by the RV, right? So if the RV apex is enlarged, that's a sign of RV enlargement as well. This is something many people are familiar with McConnell's sign, right? So McConnell's sign is basically akinesis of the lateral wall, but sparing of the apex. So you'll see the apex moving up and down, but the lateral wall won't move very much. This is very specific for PE, but you also see it in anything that can cause RV ischemia. So an RV infarct can cause that as well. Next thing we look for. Eventually what happens is the end diastolic pressure in the right heart gets too high, and it gets higher than the end diastolic pressure in the left side of the heart, and what you get is bowing of the septum. And we commonly call this the D sign. And that's essentially what it looks like. There is a technical term for this. It's called eccentricity, and there is a measurement you could do at end systole and end diastole. Look into measurements. But once again, ain't nobody got time for that. It is way too busy for me to measure this. And thankfully, again, your eyeball estimate of that eccentricity index, or the D sign, is good enough. All right, so these are ways you can assess the right heart size. There are a few pitfalls to doing this. The first is that it is truly an eyeball estimate. You have to have a little bit of practice to do this. And while there are studies that say, hey, you can look and visually estimate this and it's pretty accurate, you need a little practice to do that. It's subject to error because you may hold your probe differently at a different angle, and that can give you a different size of the RV. So it is important to get a nice representative slice all the way through this. And then lastly, we've talked about size, and we've talked about enlargement of the RV as a result of high afterload on the RV. The thing is, there are chronic medical conditions where this happens, so patients will just have very thick-walled, very large RVs. If they have COPD, they have pulmonary hypertension. It's not just acute conditions that I worry about as an emergency physician, it's these chronic things.
Now, I know we're just getting to the best part of this lecture, but I wanted to remind you about our new conference, in person with some virtual online options. Conference, it's soundandsurf.com. The dates are going to be November 6th through 8th of this year, 2024. So check it out, and now back to your video.
There is one way to assess whether something is chronic or not, and that's by looking at the thickness of the RV wall. It's something that can be measured. Usually you do this at end diastole, and it's a sign of chronic RV systolic pressure overload. And you're going to do it either in the peristernal long view at the infundibulum or in a subxiphoid four-chamber view. The measurement should be less than half a centimeter, so 5 millimeters or less. If you're doing it in subxiphoid view, or any view really, you should be wary of not measuring the fat pad with that. And there's a big caveat to this. So even when you read cardiology literature on this, most cardiologists will tell you that this is pretty inaccurate, and it's not necessarily very sensitive, but it's worth taking a look. And if you're worried someone has chronic high right-sided heart pressures and they have RV enlargement, it's often not very subtle, and they'll just have a very thick-walled RV. So that's RV size in a nutshell, right? So these are all things everyone knows, and these are things we teach all of our residents. So that's just a quick review of that for us. We're using this as a corollary of RV function. There are ways to actually quantify and quantitatively assess the right ventricle. So you can look at fractional area change. This is an interesting one. It involves measuring the RV and systole and diastole and then kind of coming up with measurements. I will never do this in my career. Again, 75 patients in the waiting room, 16-hour wait times, I will get fired. All right. Tissue Doppler imaging, everyone loves this. Is like a very hot thing, you know, diastology, and everyone loves doing that. You can do this on the right side of the heart as well. Once again, takes too long. Myocardial performance index, it looks very cool. You sound really like intelligent if you know what if you do this, but again, I don't have time for this. Speckle tracking, this is very sexy in point of care ultrasound. There's places that are doing this. It's a very hot thing to do. It also, like, I don't know, too much. 3D echoes, this actually looks really cool. I have very simple dumbed down machines in my department, and I have no opportunity to do this. And then this graph is really cool at looking at isovolumetric contraction of the right ventricle. I have no idea how to interpret this, nor do I plan on ever learning how to do it, because there is, in fact, a much easier way of assessing and quantifying right heart function, and that's looking at TAPSE, right? And again, I know this is review for everyone in here, tricuspid annular plane systolic excursion. It's basically quantifying that up and down movement we said that the right heart does. It involves measuring at the tricuspid annulus. You're going to put your marker from the apex to the annulus of the tricuspid valve, and you're going to see a wave that looks something like this, and you're going to measure from peak to trough, and that height from the peak to trough, which is automated on virtually every machine. I mean, you can just plug this in, put a line one place or a dot one place and a dot on another place, and it'll tell you what it is. And it's a marker of your systolic function. And in general, the normal values of this are greater than 16 millimeters or 1.6 centimeters are considered normal. Depending on what literature you're reading, some people will suggest that if you're a young, healthy person, it should probably be greater than 2. And some studies will use that as a cutoff for certain things. But for the most part, we're going to say 1.6 and above is normal, 1.5 and below, abnormal. All right. Thankfully, once again, some friends of ours have looked at this and they said, you know what, our visual estimate is pretty good. Not perfect, but pretty good. This was a group out in Boston and they just looked at visual estimates of TAPSE. This was not in ultrasound experts doing this. This was PAs, this was residents, and this was non-ultrasound trained EM faculty who got a brief introduction to what TAPSE is, looked at a few images, and then they showed them a bunch of other images. And they said, hey, when you look at this, how accurate are you at identifying the TAPSE and like kind of saying whether it's good or bad or abnormal? And thankfully, what they found was that at the extreme ends of the spectrum, the very normal TAPSE and the very abnormal TAPSE, people with minimal training had a very good at eyeball estimation, or very good at eyeball estimation of this. Those middle ranges wasn't exactly as accurate, but what do we care about? I care when it's really bad, or I care about what, looking and seeing that it's normal. There are limitations to TAPSE. It's one component of RV motion, right? That's that lateral wall. So you may have a totally dysfunctional RV, but that lateral wall may be moving appropriately. So when you're checking your TAPSE, you may be wrong. Conversely, your lateral wall may not be working appropriately, but the entire rest of the RV is functioning just fine and the heart's functioning fine as a result. But again, you're measuring one wall. So it's one estimate and one wall, which is why we look multiple different things. Lastly, it may be limited just by technical factors. An apical 4-chamber view is not always easy to get and sometimes just impossible to get the ideal view to measure this. And so it could be just a technically limited study. All right, so a couple of authors have looked at this and they figured out, hey, you can look at the TAPSE from other views of the heart. So this first one was called the CTAC view, and it involves looking at a subxiphoid 2-chamber view of the heart and just placing the probe underneath the xiphoid process, and you look, and they measured the TAPSE from the subxiphoid approach. And it correlated fairly well with their apical 4 TAPSE measurement. Interestingly, in both that study and this subsequent study, another group looked at just a regular straight-up subxiphoid view of the heart. So not subxiphoid 2-chamber, but just a regular subxiphoid view of the heart. And they just measured the lateral movement of that RV, and they compared it to the apical 4-chamber view in the TAPSE they got there. Correlated pretty well. Interestingly, in both studies, the cases where they weren't able to get an apical 4-chamber view, so where it was technically limited in the apical 4, they were actually most of the time able to get a subcostal view of some sort. So maybe if your apical view isn't ideal, you can do this instead. All right, so we've talked about using size as a marker for RV function. We've talked about using your TAPSE to quantify your RV function. But now we're going to move on to kind of more advanced level. So up until now, this is things that we teach, or I've taught all of my residents in our institution, right? They learn this, presumably everyone learned this. The next stuff we learn is going to be a little more advanced, and we're going to talk about hemodynamics of the right heart. Specifically, we're going to talk about flow as it pertains to the right heart. Now, I'm a little older and I trained in Brooklyn, so to me, like Biggie Smalls was like, oh, this is cool, right? No one knows what the fuck this is anymore, but like that's fine. And I'm going to pretend that this is all cool. But the reality is, this is actually some really nerdy shit. And I fully get if people are like, whatever, dude, I don't care. And I get it, I understand. But this isn't for everybody. But you all volunteered to be ultrasound people with your lives, so you're going to be subject to this torture now. So you are going to be part of the nerd shit right now too. All right, so we're going to talk about, so we've talked about like RV, like hemodynamics. We're going to talk about RV pressure. And I'm going to start by telling you, why you have to use ultrasound to do this and what the benefit of ultrasound is here. Now, when we want to know what the LV pressure is, it's easy. You put a blood pressure cuff on someone and you check, or you put an A-line in and you get an A-line, right? It's easy. I can't do that on the right side. Why not? Well, the main pulmonary artery is really difficult to get a blood pressure cuff around, so it's not like, so you just can't, I can't just like do that. And we don't put Swan-Ganz catheters in everyone anymore, so it doesn't happen, and so like you can't just like measure it like that. So what we can do instead is look at hemodynamic parameters on ultrasound to estimate our right-sided heart pressures. So I'm going to talk about finding our pulmonary artery systolic pressure, but really what we're going to do is calculate the RV systolic pressure, because we're going to assume that this is all a circuit that flows pretty well and almost perfectly without any stenosis or valvular abnormalities that may make it difficult to kind of correlate these two things. But we're going to start by talking about calculating the RV systolic pressure, because that's what we assume the pulmonary artery systolic pressure is going to be. And the way we get our RV systolic pressure is by assessing the pressure gradient between the RV and the RA. And this is one, I think a lot of people are familiar with this. The way you do that, so there's a calculation for this, and it's, sorry, I don't have a pointer on here and I can't use the arrow, but the way we calculate the RVSP is by checking that pressure gradient between the RV and the RA. There is a modified Bernoulli's formula that it goes into, and then we add the right atrial pressure to that. And that gives us our RV systolic pressure. And the way we do it is by putting, for the first part, the pressure gradient between the two. We're going to put a continuous wave Doppler gate, basically at the opening across the tricuspid valve. We're going to find the maximum regurgitant velocity, and that's what that tracing at the bottom is. It's the maximum regurgitant velocity, and that's where the cross mark is. And then you will plug this into your machine. I will never, ever in my life do this by hand. If the machine doesn't do the calculation for me, fuck it, I'm not doing this. But the machine has this. Every machine has this. So you're going to put the number in there, and the machine will calculate what this value is, right? And that's your regurgitant velocity, the max regurgitant velocity in this modified Bernoulli's equation. And then the next part of the equation was adding the right atrial pressure. And whether you realize it or not, everyone here already knows how to calculate the right atrial pressure, because you calculate the right atrial pressure by just looking at the IVC. And I say calculate, but it's not really a calculation. It's a guesstimate, basically. You're going to look at the IVC. And if the IVC is very flat and very collapsible, we give an arbitrary value of about 3 millimeters of mercury to it. If it's kind of in between, you're going to give about 8 millimeters of mercury. And if it's plethoric and not collapsing at all, you're going to add about 15 to it. And it's a very approximate number, but it approximates pretty well with what the true right atrial pressure is. So that's your RAP. So we calculated our maximum velocity, we plugged it into equation, we got into our equation, and we added our right atrial pressure, and that's going to be our right ventricular systolic pressure. And again, that's approximately exactly the same as your pulmonary artery systolic pressure. The normal values for this, less than 30 or so is okay and normal. Now, if I were to go and run on a treadmill for a while, which I definitely need to do because I added a few pounds ever since I had kids, what I would do is I could check my RV systolic pressure, and it would go up, right? Because I'm exercising, your pressure goes up, but it shouldn't really go above 40, right? So even if the normal is upper limit of normal is around 30, the upper limit, like with strain and exercise, is going to be around 40 or so. If it's above 40, in general, that's considered abnormal. Now, the way we can utilize this clinically, and we'll get to this, and I'm sure most people, if not everyone, are already familiar with this concept of the 60-60 rule, is that if there is a pressure that's higher than 60, that generally suggests that that is a chronic high right-sided pressure and not an acute change in right-sided pressure, right? So really 30 is kind of the upper limit of normal. If it's over 60, it's probably a chronic issue like, again, COPD, pulmonary hypertension, something else causing this patient's high right-sided heart pressure. All right, the next parameter we're going to discuss is the pulmonary acceleration time. So we looked at pressure in the right side of the heart. We're now going to look at pulmonary acceleration time. And that's basically how quickly blood comes out from that vein, from that pulmonic valve, and reaches maximum velocity. And we use it as an estimate of the mean pulmonary artery pressure again. All right. So you're going to put your pulse wave Doppler across that pulmonic valve. It'll give you a tracing that looks like this. The way you find that pulmonic valve view is by going from a peristernal short, fanning towards the base, finding your aortic valve there, and then what you'll see above the aortic valve is the RV outflow tract. You'll see the pulmonic valve adjacent to it there, and then you're going to put your pulse wave Doppler gate basically right at the annulus there, and then what you'll get is a tracing that looks something like this, once again. And again, this is a simple calculation that your machine will do for you. You're going to put one marker at the start of that wave, right? This is blood coming out, and then you're going to put another marker at the peak of that wave. And what the machine will tell you is what that space is between the two. And that space is measured in milliseconds. It's how long does it take to go from start to finish. When I first read about this, I was like, oh, okay, that kind of doesn't make sense. And then I was talking to someone else who does this much more than I do, and they explained it in a very conceptually easy fashion for me. What you're doing when you're doing this is basically, if you think about water from a hose, if you just turn a hose on, water is going to come out, and it's going to come out at its gradual rate that the water comes out at. If you put your finger at the end of that hose, the water is going to come out with a little more pressure, and it's going to reach, it's going to get faster, basically. It's going to accelerate a little more. This is basically looking at like whether there is a finger over the end of the hose or not. Because if you think about it, if there's something obstructing this flow, then it's going to get to its acceleration, its peak velocity. It's going to accelerate more rapidly, right? So it's going to reach peak velocity faster if there's something obstructing it. So a normal pulmonary acceleration time is going to be somewhat like, it's going to be around 130 milliseconds or greater than that. And if you have a very rapid pulmonary acceleration time, right? So that acceleration time is shorter. If it's less than 60 milliseconds, that suggests acute obstruction. Again, this is the other component of that 60-60 rule, right? So it reaches peak velocity more rapidly because there's, again, finger at the end of the hose, whatever that is. Let's say a clot. All right, so we talked about RV function, we talked about hemodynamics. I'm going to close for a few minutes with kind of utilizing this clinically. And as I said, the way I utilize this clinically is 9 times out of 10, it's going to be in PE patients, either suspected or confirmed pulmonary embolism. I like to look at these right ventricle parameters. And the reason is, and my reasoning behind this, and the reason, again, why I drone on and on with my fellows about this is because, how we manage PEs varies based on certain parameters we find. So to take a step back, I'm just going to go over some things about PE in general. There are different ways of defining PEs, high risk, low risk, intermediate risk. I like simple things, massive and submassive in my mind. This is what I care about. So massive PE, as we all know, is a PE with a clot burden that causes hemodynamic instability, right? Your systolic blood pressure is low, or you have a drop from your baseline that lasts for a while, or you have clinical signs of shock. That's a massive PE. Submassive PE is this is the kind of the box that I really care about, right? Because massive PE, you can make the argument they just need lysis, or if they're stable enough, get to the lab where they can do catheter-guided lysis. Submassive PE is the one I care about. This is the patient who's got clot burden, but they're normotensive, right? So their blood pressure is fine, so people want to kind of ignore that or poo-poo that, but we define submassive PE as someone who's got a normal blood pressure, but signs of RV dysfunction. And this is where every point-of-care ultrasound user, whether you're fellowship trained or in fellowship or just a run-of-the-mill ER doctor, should know how to do some of this, if not all of this stuff. And that's looking for signs of RV dysfunction. And again, part of the definition of submassive PE are exactly the things we've talked about. RV dilation, systolic dysfunction on echocardiography. All right, and again, this goes back to pathophysiology. When we talked about the anatomy of the right ventricle, remember, this is a very afterload dependent system. The second there's a change in the afterload, you're going to get stretch of that thin wall and you'll get dilation of the RV. And what does that cause? The things we talked about. RV enlargement, the D sign, and abnormal TAPSE. But do keep in mind that there's going to be a subset of patients in whom they have the risk for PE, but they have other heart problems that cause like abnormalities in their heart structure. Common ones are going to be COPD, CHF, pulmonary hypertension. These are the things that I encounter where PE is on the differential, but their heart already out of whack. So I can't just look and say they have RV enlargement or not. This is where utilizing the 60-60 rule comes into play. And again, we've talked about this already. It's looking at the pulmonary acceleration time and the tricuspid regurgitant gradient. This was the original study published on this. It's 21 years old at this point. They looked at a handful of patients who had PEs. It's been like repeated in another like little twists and turns on this, but this was their original paper that was published. What they found was that if they looked at their 60-60 sign, patients who met the qualifications for it, it had about 94% specificity for pulmonary embolism. So very specific for the diagnosis of PE, but not sensitive to rule out PE. And again, what this involves, and I want to make this distinction, it's not the actual RV systolic pressure you're calculating, you're just looking at the tricuspid regurgitant gradient. That was part of the original 60-60 study. It was just the tricuspid regurgitant gradient that we talked about, right, that your machine will calculate for you, and then your pulmonary acceleration time. And if the results are that your gradient is less than 60 millimeters of mercury, and your acceleration time is less than 60 milliseconds, that suggests that there's probably something acute causing an obstruction there, right? Remember, high right-sided heart pressures that are chronic, they'll have a very elevated right-sided heart pressure, and their pulmonary acceleration time may be in the abnormal zone, but not a rapid acceleration time there. All right, some other people who are very smart looked at some of these parameters, and they noticed that when you're looking at the acceleration time, you may have an abnormal waveform when you're doing this. We showed you acceleration time and it looked like a nice normal curve, But what happens in the setting of an obstruction is you get what's called systolic notching. And in pulmonary embolism specifically, you get what's called early systolic notching. So early on in that wave, you get this little wedge shape to it there because of the flow. And in this original study that was done on early systolic notching, they had amazing operator characteristics for this. It was 99% specific and 92% sensitive. Unfortunately, on repeat exam and repeat study, those numbers haven't exactly panned out, especially the sensitivity part of all of this, right? So this was a subsequent study that was done in Turkey, and they looked at the 60-60 sign and early systolic notching in PE patients. And in their study, the sensitivity was only about 34%, but it was still a very specific sign. So 97% specific. Another study done in India, again, not very sensitive, but very specific. But the thing I like about this and the reason to utilize this, obviously it's a very specific test, but also in their study, what they found is they looked at mortality in their PE patients, and the single best predictor of mortality was early systolic notching on this pulmonary acceleration time. So, kind of bringing it together, how good is echocardiography in the setting of PE? That's a very difficult question to answer. Because, I think the consensus, most people will tell you, is that it's not the most sensitive test, but you have findings that are very specific for pulmonary embolism. This was a study a handful of friends of ours did in Boston a number of years back, and they looked at PE patients, specifically patients who had centrally located PE. And the reason I like studies like this is because these are the ones I care about. Big PE or hemodynamically unstable. That's when I want to use all of this stuff. And unfortunately, nothing specifically was that sensitive. None of their individual findings was very sensitive. But when they combined TAPSE, McConnell's sign, D sign, and RV enlargement, it was about 90% sensitive for centrally located PEs. So there's a follow-up study that these folks and some other people did that looked at patients with PE and abnormal vital signs. And in this study, abnormal vital signs was defined as heart rate greater than 100 or systolic blood pressure less than 90. And again, the sensitivity by combining those factors, the TAPSE, RV enlargement, D sign, and they added the tricuspid regurgitant velocity here, what they found was that their sensitivity was about 92%. Very good, not perfect. But when they did a subgroup analysis of their patients who had a heart rate that was elevated, so not low blood pressure, but high heart rate and PE, what they found was when they combined all of these in their focused cardiac exam, their sensitivity was about 100% in their patients. I will say, there's no such thing as 100%, right? Like statistics people will tell you there's no 100% in any stats, and there's no such thing as 100% in life. They say death and taxes are 100%, are guaranteed. They're not. Keith Richards is still alive. If you're any Rolling Stones, Keith Richards is still alive, and if you live in Saudi Arabia, you don't pay taxes. So there's no guarantees in this world. So nothing's 100%. But that's still a pretty good operator characteristic on this. And then switching gears, so now we're talking about diagnosis of PE. The thing where this helps me also is prognostically. So this was a study where they looked at patients who had PEs and they looked for signs of RV dysfunction, and they said, how many of these patients have bad outcomes? Well, any sign of RV dysfunction on goal-directed echocardiography was pretty specific for adverse events in the hospital. And then again, this is the kind of TLDR slide, and I'm out of time, so I'm sorry I'm running over, I apologize, but this is like the second to last slide. So the long story short of this is, especially your TAPSE, of all the things that we've studied, probably the TAPSE is the one that has shown the best prognostic value in pulmonary embolism. And a number of different studies, the author of one of these studies, some of you are in the room here, basically what they found is that if your TAPSE is less than 15, that's going to predict poor outcome, whether that poor outcome in some of these studies was mortality or needing a procedure or adverse events in the hospital within 30 days. TAPSE is probably in a number of studies the best predictor of poor outcome in PE patients. So for me, it's not just I don't know if this patient has a PE or not, it's this patient has a PE and I need to know how sick is this person actually going to become. All right, bringing it all together. So everyone knows how to do the right heart stuff. This is, again, I teach every resident we go over the heart with, I teach them this. This is something I feel like every EM resident should learn at this point. But again, you're all very highly educated, highly trained ultrasound people, so it's important to learn the fancy calculations that we need to know in evaluating the right heart. And I'm just going to end right there because I'm over time. Apologies. So thank you.
so thankful to have learned so much from Dana. He's actually an amazing person, so smart, and the way he teaches is very for the ER doctor. It's not, I mean, it's like a highbrow, but bringing it down to like medium to lowbrow, just making it so accessible. Check out the TAPSE study, please, or TAPSE. Check out soundandsurf.com. If you want more content, go to courses.coreultrasound.com. And remember that there's the Ultrasound Leadership Academy. It's a nonprofit where you can have a year-long ultrasound fellowship. We have one-on-one content, one-on-one hangouts, and that's ultrasoundleadershipacademy.com. I hope to hear from you soon, and happy scanning.